The diagnostic classical microscopic appearance of neuroblastomas are pretty interesting. Classically, there are two terms that are used, which if you see them, and they can usually be seen easily, pretty much cinch the diagnosis microscopically. And there are a lot of backup things we can do to prove it as well. Uh, I'll open the door to a word called neuropill. Neuropill is usually unmyelinated fibers, nerve fibers, which are seen in neuroblastomas. And it's not always easily seen unless you have good histology. One things that are easily seen are rosettes. And rosettes, we'll show you what a classical rosette looks like. I can't think of any other disease or any other tumor in which the term rosette is applied except for a neuroblastoma. It's like a whole bunch of nuclei sitting around a central area of neuropil, or what might look to you just like cytoplasm. Uh, if These are usually don't need immunochemistry, but often they're done. If you do them, you will, and you use immunoperoxidase, you will see a neuron-specific enolase, which is a mark that this tumor is a neuroendocrine tumor, like other neuroendocrine tumors, like oat cell tumors, and a whole bunch of other things. And if you do EM, you will see the classical types of secretory granules that you see in the pheochromocytomas, in other words, catecholamines. As you might guess, if the tumor has a high mitotic rate, it would be an unfavorable prognosis. But if you see further differentiation, like into Schwann cells or ganglion type structures, multinucleated ganglion like cells, that's a favorable indicator. There are other prognostic predictors as well, both clinical uh, uh, and pathologic, which pathologists and oncologists use to give a general indication to the parents, how this tumor is going to behave. Okay, let's quit talking and look at some pictures. You see these fine little strands in here? This is a good slide. This is neuropil. What these are basically unmyelinated fibers, axons, dendrites, and basically if you do a good stain you can see it's not just pink cytoplasm, it's fine spindly type stuff. Of course that could be better seen on EM, but the one thing you don't need the EM to see are rosettes. Take a look at these two asterisks here. This is a classical rosette. Sometimes they're called Homer Wright rosettes, named after a couple of doctors, and one of them was not Homer Simpson. But a classical rosette is diagnostic of a neuroblastoma, and in it you have a bunch of peripheral, almost palisading like nuclei sitting around a central, more fibril area that looks more like neuropil. So just if you're into buzzwords, when you hear neuropil regarding tumors or rosettes or Homer Wright rosettes, you're talking about a neuroblastoma. Here's another area to show you in general how vascular these tumors are, like most malignant tumors or neuroendocrine tumors. All of these little red areas are blood vessels. And look, if you did a cross-sectional quick estimate and said what percentage of this tumor consisted of blood vessel spaces, you have to say a lot. Here it looks like to me like about maybe 10, 15, 20%. These are very vascular tumors. Here is a type of neuroblastoma in which we see some multinucleation, like here and here and here. And this implies that it wants to differentiate even more into so-called ganglion-like cells. This neuroblastoma may be called a ganglioneuroblastoma for that reason. And like we said, because these cells have a higher degree of differentiation rather than just your classical small round blue cell tumor, this one's expected to be behave more favorably as well. The behavior of these is like any malignant tumor. They metastasize through blood, vessels, and lymphatics. They go to liver, bone. They are very serious tumors. They're malignant tumors. Nevertheless, If they occur in a younger end of the scale, like less than 1 year rather than more towards the third or fourth year, they're a really good prognosis no matter what the stage is. And once again, this is the concept of malignant tumors in children spontaneously regressing uh, by virtue of the fact that they mature, rather than just go away. And a bad feature is if there's amplification of the N-MYC or MYC oncogene, and that's present in about a third of the cases. And if you see it, it's not a good prognosis. It means that the oncogen is being amplified. Uh, if you take all of these factors, including the histologic factor and clinical factors, uh, you can divide the neuroblastomas into low and high risk. And as you might guess, a low risk would have a good prognosis. I think a 90% cure rate is a good prognosis. And of course, a 20% cure rate is bad. And the opposite of that 20% usually means death. Another thing to remember is that in the pheochromocytomas, you have a big production of catecholamines, and that results in hypertension. Well, there's a lot of catecholamine production in the neuroblastomas as well, but you normally don't get hypertension secondary to that. That's another little pearl you can keep in mind. Now we're down to the very last tumor, solid tumor of kids. We're not going to go into the leukemias and lymphomas because we'll go to that in great detail when we talk about the lymphatic and hematologic systems. I think we'll save these last few slides on Wilms tumor for another clip because I want to make another little rant at the very end because that will be the complete end of the 10th chapter, which means it'll be the complete end of the whole discussion on general pathology. See you on the flip-flop. Bye.